Health Promotion Seminar Series. This is a collaborative effort between the Community Health Nurses Initiative Group and the D'Souza Institute. The seminars offer an opportunity for professional development for nurses working in all domains of practice, community, or acute care. For information, please feel free to check out their websites. Welcome to our webinar, Healthy Sexuality in Our Aging Population. My name is Tammy Chartwood, and I'm the Sexual and Reproductive Health Specialist for Alberta Health Services, and I'll be one of your speakers today. I have with me my colleague, Heather Cobb, and she'll introduce herself later in the series. This cartoon is just for fun. The old guy says, "Whatever happened to our sexual relationships?" The woman says, "I don't know. I don't even think we got a Christmas card from them this year." So what's ahead? The objectives of this course for you today are to increase your awareness and knowledge of issues of healthy sexuality and aging, including typical age changes and common sexual dysfunctions. We hope to increase your knowledge about trends about STIs, HIV, and other reproductive health concerns in our aging population. And finally, we want to increase awareness and skills for you working with sexually and gender diverse people and their families. So, why do we need to talk about healthy sexuality and our aging population? I don't think it's going to come to anybody's surprise about the stats about Canada's aging population. In fact, as of July of 2015, our population of people aged 65 years and older is now larger than the number of children under the age of 15. In fact, as this trend continues, people over the age of 65 will account for 20% of our total population by 2024. To compare that, children aged 0 to 14 years will only account for about 16% of the total population. So, let's talk about seniors and sexuality and offer some perspective. Who are we talking about? We're talking about those baby boomers born around 1946 to 1965. They're the first generation to experience education, employment, and welfare services better than those of the parents before them. What we know is that the average 65-year-old is expected to live another 13.3 years. I think that's really good news for all of us that have worked very hard in our careers and are looking forward to the retirement. What we know is that the current generation of baby boomers are now more active in their 60s than in previous generation people who were in their 40s. Along with increased vitality due to advances in health, we have pharmacological advances such as Viagra and Cialis and hormone replacement therapies, and all of these factors contribute to increased sexuality later in life. So as registered nurses, let's talk about seniors and sexuality. Why is this something that we need to talk about from a healthcare perspective? We need to talk about it from a healthcare perspective because we know that healthy aging is far more than the absence of disease. As the aging of our baby boomers increases, new demands on our healthcare system include a new view and integrating of supporting healthy sexuality across the lifespan. Some considerations include building comfort and capacity in our healthcare professionals to support our seniors with healthy sexuality. We need to look at and think about developing age-related specialty services regarding healthy sexuality in our aging population, and also build the foundation for healthy sexuality by developing policies that support supportive living and long-term care facilities.
Hello everyone, my name is Heather Cobb and I am the Sexual Health Promotion Specialist with Alberta Health Services in Calgary, and I'm joining Tammy today to take you through this webinar. And so first of all, what do you think senior sexuality actually looks like? We're going to start with a short video which takes one person's understanding of what it means to be a sexual being as you become a senior.
different kind of sexy as I get older. It involves all of me, my whole self, not just limited parts of me. Sexy means looking after myself to the utmost. My health, my mental self, my physical self. Sexy means being open to everything, to the young and to the old. Sexy means being ready for the possibility of finding love. I have to admit, some days I feel a bit jealous of the new generation when it comes to sexuality. In my day, there were so many restrictions. Taboos about sleeping with someone you really loved. You were a slut. Add to that discrimination and racism. In my day, you couldn't care about someone from a different religion, let alone a different culture or race. Awful stuff. And let's not talk about pregnancies out of wedlock. If you got pregnant, you were sent away, banished from society. It was disgrace. Now today, look at all these single mothers. It is amazing. The world kept going. No one blew up. It wasn't the apocalypse. It is okay. How sad when a whole lifetime was wasted being unhappy or playing by other people's rules, when there were possibilities for total happiness if all these beliefs and taboos would be ignored. But that took courage of a sort that a woman of my generation couldn't imagine. Thank goodness things have changed for younger generations, but have they changed for our generation? Have we paid attention and kept up? Or do we live with these taboos, misinformed beliefs, and hateful thoughts in our heads still? You know what? I think sexy means thinking better all the time. Sexy means challenging myself to keep living and being human. I am bringing sexy back.
So first of all, I want to acknowledge that not everybody feels comfortable talking about sex and sexuality, and I find it's helpful to use this slide to help us understand the difference. For many people, when we refer to the term sex, people either think of their biological sex, so male or female, or they think of sexual acts, so taking part in some kind of sexual activity. What we do know is that that's different from sexuality. Sex is part of sexuality, but sexuality is a far more holistic concept, and when we understand that concept, it can help us understand how it can influence all the people that we work with. This is the sexuality wheel, and the sexuality wheel shows how broad the concept of sexuality really is. Imagine it is a wheel with spokes coming out of the center. Each spoke of the wheel represents one part of who we are, and they're all connected and influenced by each other. On the left, we have the spokes that point to the pieces of who we are by nature, our personality, how we express our gender, our sexual orientation, which means who we're attracted to. And on the right, we have the concepts or the ideas, the traits that we're taught, how we're taught to have healthy or unhealthy relationships, communication, how we feel about our body image and our self-image. When all the wheels of the spokes are in good shape, the wheel moves freely and smoothly. When all the parts are healthy, our sexuality is healthy. So why consider values and assumptions? Before you started listening to this presentation, you will have most likely come to this presentation with some values and some assumptions. In fact, you may have shared with a colleague or a family member, I'm going to be listening to a webinar about seniors and sexuality, and you may have even had a few giggles. So here are a few myths or stereotypes that you may be familiar with. The first is is that sex is only for the young and the beautiful, and that an aging body isn't sexy. Think back to that first video we saw. She certainly doesn't agree with that. And that idea that sex is for the young and the beautiful really media, and it comes from younger people. And so that's something that we want to challenge. Sex isn't as important in a relationship as someone ages. There's this kind of idea that couples become comfortable with one another and that sex is no longer important. And in fact, we know that sex can be a very important piece of someone's relationship until they feel that they don't need to have sex anymore. So we really want to challenge this idea. It's really interesting because when I am working with younger people, one of the questions I sometimes have had in the question box when I'm in a classroom is, do people have sex in the old folks' home? And so there is this idea that older people, in fact, don't have any sex whatsoever. And as Tammy's going to go on and explain to you, that's not the case. We know that older people are definitely having sex. And in fact, this next myth that sexual dysfunction is inevitable, that the equipment doesn't work, is not in fact true. There are definitely some age-related changes, but that doesn't mean that someone can't have an enjoyable and healthy sex life. And the last one is that sex just gets vanilla as people age. And, you know, I think we should leave that to everybody else to make their own decision. But for many people who are in older age, that's not the case.
Ages and stages. So we're really lucky in Canada to have a brand new report that was just published in May of 2016. And the study is a partnership between the Sex Information and Education Council of Canada, also known as CHNIG, and also the Trojan Condom Company, which gives me a bit of a laugh, actually. But within the study, they looked at sexual health at midlife, which looked at the sexual health lives of 2,400 Canadians, divided equally between male-identified people and female-identified people aged between 40 to 59 years old. But what they were looking to see is just how sexually active is this group of people. And of the people that responded, just over 50% reported at least one sexual partner in the last year. Of those people, in fact, more than half the men and about a third of the women reported having 2 or more partners in the same time frame. A previous American study of about 3,000 people aged 57 to 85 found that nearly 3/4 of people aged 57 to 64 reported that they were sexually active. Nearly 1/2 of people aged 65 to 74 were sexually active. And very impressively, nearly 1/4 of all people over the age of 75 reported that they were sexually active. So as Heather mentioned earlier, there are definitely some normal natural aging changes that are important to be aware of, because when we understand what the natural changes are within aging and the impact to sexuality, we then can identify what is abnormal or sexual dysfunction that might need some further investigation. So there are some commonalities in terms of natural aging for both men and women. So people may find that there are changes in our relationship status, including divorce and death, which might limit our opportunities for partner to sexual experiences. People may find that age-related body changes may impact their body image, self-esteem, and feelings of desirability. During sexual intercourse, people may notice some actual physical changes as well. Commonly, it might take longer to become aroused, might not have as much stamina, might need more time to actually reach the same level of enjoyment, or not able to reach the same level of enjoyment as in previous years. I think there's a big gap in the data because, in fact, there's very few studies that address the experiences of aging adults and self-pleasure or masturbation. So I don't have that information to offer to you, but I think it is a real consideration for future research. So what are some of the natural aging changes for women? I think it is important, as Heather mentioned, to understand that there are some natural aging changes. For women, oftentimes these changes are connected through the transition through perimenopause to menopause, and many of which may occur, including changes in arousal and desire as a result of decreasing estrogen levels, some menstrual changes from having sort of regular predictable menstrual periods to random spotting and bleeding that becomes unpredictable. Good old hot flashes, night sweats. A lot of women will experience changes in the vaginal lubrication, which can occur as the walls become thinner and less elastic, and lubrication can become slower and decreased in volume. We might see changes in our urinary continence, including accidental leakage, increase in bladder or urinary frequency, and a very common vaginitis, which is that increase in vaginal infections, as well as possible increase in bladder infections. Another consideration for women is, for some people, a woman's sexual identity may be very closely connected to their ability to have children. So the loss of reproductive capacity or transition from perimenopause to menopause may impact her sense of self and her sexual identity. So let's talk about natural aging changes for men. With natural aging comes lowering of testosterone levels. Some people affectionately call that menopause, which may lead to a need for increased stimulation, less firm or frequent erections, shorter and less sensation with orgasm, with longer time to recover in between. Some people may find that they have a less forceful ejaculate with less semen volume in that ejaculate, and again they may experience the same urinary concerns with changes in incontinence and accidental leakage. So with aging, as we all know, comes many other health considerations, chronic conditions, and illnesses that may impact our sexuality. As you can see, the list is long for chronic conditions. And so what I would challenge you to think about is, as you look at this category, how might these chronic conditions actually impact somebody's sexual identity and sexual function. And so a very typical one might be arthritis, when we talk about limitations in movement and chronic pain and self-image, and what that impact might be to that person's sexuality and relationship with their partner. In top of the chronic conditions and illnesses, then the list of medications comes along with that. And of course, you, I'm sure, are aware that there's many medications that actually have some implications for sexuality, and many people come to you with that patient profile of polypharmacy, where in fact you need to actually sit down with patients and examine what they're on and think about what those implications might be to sexual functioning. The one that I want to point out at the end is the impact actually of recreational drugs onto sexuality. Many people forget to ask about recreational drug use, which actually includes alcohol and nicotine, cannabis, and harder street drugs. But in fact, each of them have unique implications to a person's sexual functioning. So let's talk a minute about common sexual dysfunctions. I think it's important to point these out because, again, we have some natural age-related changes when it comes to sexuality, which are pieces that we might be able to talk through, which is some good conversation with our patients and clients. And then we have true sexual dysfunction, which in fact we might want to engage specialists or other healthcare providers into the conversation. So for females, typically when we talk about common sexual dysfunctions, we're concerned about inhibited sexual desire, lack of ability to orgasm, pain with intercourse, and vaginismus. For men, oftentimes discussions may center around erectile dysfunction, or affectionately known as ED, premature ejaculation, delayed ejaculation, retrograde ejaculation, and anejaculation, which means no ejaculate. Let's talk about STI risk. We know that people are having sexual intercourse as they age, and in fact at fair numbers. Again, let's touch base to that study that was just published in May of 2016 between Trojan and CHNIG and the midlife study. What that study showed us is that about a third of single men and about a quarter of single women reported using a condom at last sexual intercourse. Compare that to university students. This is a pretty interesting statistic, that when you compare those rates to the university crowd, 61% of men and 50% of women report using a condom at last sexual intercourse. I think those numbers are pretty telling because, in fact, what we see quite consistently across many studies is that condom use declines with age. So why was I telling you about STI risk and making the connection to condom use? Well, we know that condom use is a cornerstone to safer sexual practices. And in fact, when you look at some of the STI rates across time, what we're seeing is that within an aging population, we have dramatically seen an increase in STI rates from the year 2003 to the year 2012. So what I want to point you towards, the very last categories for people aged 40 to 59, and then again the last category, which is 60 plus. If you look at the year 2003, we see that the chlamydia rate per 100,000 for the 40 to 59-year-old crowd was 27.1 cases per 100,000 people. I want you to speed that up to the year 2012, and that rate has gone up from 27.1 to 61.6 cases. That's a threefold increase in chlamydia rates in less than 10 years. Even as interesting to me is when we look at the next age group, which is the 60 plus crowd. In the year 2003, the chlamydia rate for that crowd was about 2.9 cases, or 3 people for every 100,000 reported positive chlamydia or had positive chlamydia tests. Again, you fast forward that to year 2012, and again that number has also doubled, where at that point we're now seeing about 6.3 cases per 100,000. I do want to make a note regarding the delay in statistics and the information that's available through Health Canada. I know that these seem quite dated statistics, but in fact they are the latest and greatest in what's available through the Public Health Agency of Canada. Again, it's a bit of a gap in terms of how rates are reported on the subject, but it's the best we have, and clearly there's a trend that we see in this data. So again, let's talk about syphilis, and we're going to look at syphilis rates by age group. Again, it's between the year 2003 to 2012, and we're going to look at the statistics for the 40 to 59-year-olds and also the 60 pluses. So for 40 to 59-year-olds in the year 2003, the rate of syphilis was about 6.6 cases per 100,000 people. Fast forward that to the year 2012, and we now see a rate of more than doubling to 14.8 cases. When we look at the crowd for those 60 and older, in the year 2003, syphilis was reported as 1.4 per 100,000, and again we see a true doubling of that rate in 2012, where that now has gone up to 2.8 cases per 100,000. The data for a new HIV diagnosis by age group is a little bit more current, and so here's a graph from the Public Health Agency of Canada demonstrating new HIV diagnosis starting from the year 2009 to 2014. What we see in 2014 is that the largest proportion of HIV cases were still diagnosed among people aged 30 to 39, but look what follows that. Following that, we see 22.8% of new cases in the age group between 40 to 49 years. And in fact, the proportion of HIV cases among those aged 50 plus increased from 15% in 2009 to 21.9% in 2014. When you look at risk factors and HIV, where we're seeing the largest proportion is still with our population of MSM, or men who have sex with men, IV drug users, but not far behind that is Indigenous women have alarmingly high increases in their rates of HIV. Let's put pregnancy back on the radar. Pregnancy and fertility are still a concern. It's a very common myth that people don't need to worry about contraception after the age of 35 because the risk of pregnancy is so low. I'd like to really challenge that myth because, in fact, we know that women can conceive a pregnancy right up to menopause. But let's remind ourselves what the definition of menopause is. Menopause is just defined as the time period after a person has not had a period for 12 consecutive months. The average age of menopause in Canada is 51 years. The next statistic I think is quite alarming and might shock some of you. So in 2014, Canadian women over the age of 35 had 12,500 induced abortions. So those are intentional ending of pregnancies, not spontaneous abortions, which accounts for a full 15.3% of all induced abortions in Canada. Clearly, there's a lack of understanding for women as we age in terms of the risk of conceiving a pregnancy and the need for continued reliable contraception right through until menopause is confirmed. So now that you have some background information about our aging population, common changes related to sexuality, some considerations regarding STI, HIV, and reproductive health, what the end goal here is to increase some awareness and comfort about having these critical conversations with our patients and clients. Although healthcare professionals have been shown to be the preferred source of health information, they often leave sexuality off the conversation. What I want to do is give you some practical tips about how do we create those safe and comfortable spaces for people to talk. I think, of course, very important is the environment. We want to make sure that there's a safe space and ensure some privacy. We want to make sure that people are aware that these conversations are confidential. We need to make sure that we use a sex-positive tone, which means that we talk about sexuality as a part of the healthy human experience and that we want to normalize these conversations. But first of all, we want to give permission to talk about sexuality and then get permission to talk. So what that might look like is, you know what, I want to let you know that being sexual is a part of the human experience. Are we okay to talk about that today? So it's sort of giving permission for somebody to talk, to approach you. Maybe it's not going to happen today as this part of the conversation, but then you're going to get permission for them to talk about it. We want to move from general to specific language. So don't delve right into their sexual practices when you haven't asked if they have a partner. You know, you want to use some gentle hands and guide the conversation. So start from sort of a general and safe topic and get down to the specifics. We want to use neutral and inclusive language. Heather's going to talk in a little while about the use of inclusive language. And again, normalize, 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 and validate that patient's experience as being important. So safer sexual practices. Remember we talked about that condom use declines over time. I think this is a good reminder for all of us, just both in our personal lives, but also in our professional practices. There's what we call a hierarchy of preferred sexual behavior. And what I wanted to do is just present some of that information. You know, how can we support patients and clients towards safer sexual practices? And for those people that are sexually active, protection, which is talking about using and having condoms and dental dams available to people, and making sure that they understand the connection between the use of condoms and dental dams to prevent sexually transmitted and bloodborne infections, and where applicable, pregnancy. We need to make sure that we're encouraging testing and treatment for STBBIs. And most important is actually communications between partners. Encourage people to talk to their partners about their previous sexual health histories, about having regular testing and disclosing of any STBBI infections that have happened or are current. I think sometimes we forget to talk about STBBIs, but things like the viruses such as genital warts, for example, or herpes, for example, are lifelong conversations that need to be carried on right through as people age. We need to make sure that people are talking to their partners, know personally what their boundaries and sexual limits are, and being able to communicate those with partners. Of course, making sure that people have consent and understand what capacity to consent is. Consenting means that we're asking for permission to proceed with each and every sexual activity and not assuming that just because we did it last time, it's okay to do it this time. Heather's going to talk a little bit about considerations about capacity consent a little bit later. And of course, reminding people, in fact, that abstinence is a choice and it is a preferred option for safer sexual practices if you're not in a consenting and consensual relationship.
So what do we mean by consent to sexual activity and having capacity? It's very common for long-term care staff to question sexual consent issues with the people that they work with, because ultimately long-term care facilities have an obligation to protect its residents. And consent for sexual activity is quite different from consent for medical treatment, because when someone is consenting to sexual activity, chances are they are alone and they're having to make very quick decisions and responses. When they're making consent or giving consent for medical treatment, they may have a partner, another staff member with them, or a family member to help them weigh up the pros and the cons, to go away and find out more information. But consent with sex happens quickly. Most standards for consent in North America use the following criteria. So they want to know that the person giving consent has knowledge. So making sure that they are aware of the risks that could happen. So some of the risks that Tammy's already taken us through of STI and pregnancy, the responsibilities that could occur after that, the responsibility, for example, if a pregnancy or an STI occurs, and how appropriate is that behavior as well? Where is that behavior taking place? They also want to check for understanding, that the decisions comply with the individual's values, and that the consequences that could come from this sexual activity are understood, what can actually happen. And the last piece is around voluntariness. So that person being able to make a choice to consent to that sexual activity without any coercion, and that if they are to say no, or the other person says no, that they stop, so that once consent is withdrawn, that sexual activity actually stops as well. And when people are making a judgment around capacity to consent to sexual behaviours, it's very useful to think about the full medical history and to understand that client's memory and cognitive abilities, and to use those assessments to make that judgment. So we are going to slightly change now, go on to one of our other objectives, which is looking at gender and sexual diversity. And a very important aspect of sexuality for all of us, regardless of our age, is gender identity and expression. So the next few slides will come across, will address this topic and give you some background information. This has become increasingly important as Tammy and I, certainly as we've been preparing for this webinar, and as we've been doing some of the work that we do around working with gender and sexually gender diverse populations and stakeholders, is we've heard an expression that when people age, and particularly when they go into long-term care, they go back into the closet. So you may be familiar with that term, coming out of the closet. So telling others around you, your family, your friends, your colleagues, about your sexual orientation, about your expression, about your identity. And in fact, the whole concept here is that when people get older, unfortunately, they have to deny themselves their true understanding of who they really are, and they go back into the closet. And so terms that you may have seen and you may be familiar with are the acronym LGBTQ, and we also have an I included there as well. So those words might not be that unfamiliar to you. I just want to quickly say a little bit about terms. I've included a quotation there. Labels are for filing, labels are for clothing, labels are not for people. We do need to be careful with definitions and terms, because they can put people in boxes and they can make people feel different. What we want to do here is give you terms that will help with your understanding, and with increased understanding will come your ability to better serve the patients and clients that you work with. So another letter that you may see in the acronym sometimes used is the letter A, which means being an ally. As healthcare providers, our goal is to support our patients and clients in the best way that we can. And when we are an ally, we advocate for human, civil, and sexual rights of sexual minorities. We challenge discrimination and heterosexism, and we find ways to make sure that we understand what human rights actually include. And in the last year or so in Canada, in Alberta and in Canada as well, we've definitely seen a move to legislation that means that we no longer are able to discriminate against people because of their gender or their sexual identity. And that includes in our workplace, but also in our families. And as we move through our friends and our social lives, we are seeing much more of a goal to be for everyone to be an ally. So we already talked a little bit about sex versus sexuality and the definitions. Here we have the term sex and gender. So as I said originally, sex really is around the categories. That's often how we assume sex to mean. But sex is the categories male, female to which people are typically assigned at birth. I like to say it's that moment when they hold up the baby and they say, it's a boy or it's a girl. And that sex assigned at birth typically appears on proof of identity documents, unless a person has their documentation changed. The difference is with gender. Gender is a person's internal sense and experience of identity as male or female, but it can also be as both or neither, and that is regardless of the sex assigned at birth. I think it's important to talk a little bit here about sexual orientation and gender identity, because sexual orientation, who attracted to, is not necessarily the same as your gender identity. So we define sexual orientation as a person's emotional and sexual attraction to others, and it can be fluid, it can change, and it may or may not reflect sexual behaviors. Our gender identity is our internal sense and experience of identity as female, male, both or neither, regardless of the sex we were assigned at birth. And our gender expression is how a person publicly expresses and presents their gender. And this can include appearance, name, pronoun, and social behavior. And so one way that we try to understand orientation and gender and look at how we can recognize people as all being different is around using a sexuality spectrum. And what we recognize is that some people clearly identify as one orientation or one gender, but for others it's completely fluid, it's less defined. And recognizing orientation and gender as on a spectrum may be more accurate than viewing it as being divided into distinct categories. So as you listen to this PowerPoint, you're probably thinking, so what? And that is an important question. We want you to be able to take some practical skills and understanding away from this webinar. What we do know is that a person's experience of stigma and discrimination is going to impact the way that they relate to you as a healthcare provider. And if they have a bad experience, they are less likely to access care. They're less likely to talk to you about their sexuality and their health in general. And that will then lead to negative health and social outcomes. So it's not actually being LGBTQ that creates barriers for our clients, it's actually their lived experience. It's what's happened to them previously, the stories that they've had to tell, the discrimination that they faced, and having to tell those stories over and over again. So if we can come to the table with our clients and be open and understanding and give them a good experience, they're more likely to come back and access care in the future. And so what does this mean for people's health? We know that people who identify as being sexually and gender diverse are going to be at higher risk for some of the baddies, you know, the ones that we're very used to seeing as problematic within our healthcare system, costing our healthcare system lots of dollars, but also having long-term impacts on our clients, things like heart disease and obesity, but also mental health concerns. We do know, unfortunately, that folks who identify as LGBTQ are definitely more at risk for mental health concerns such as anxiety, depression, and suicide. This can actually lead to increased substance use and interpersonal violence. And then this might be an interesting one for you around certain cancers. So when we're dealing with our trans folks, if someone identifies as one gender, but in fact they're not given the right screening test for cancer, they may actually run into problems with their health in the future. And what we do know as well is that they are less likely to participate in health promotion activities such as screening, for example, cervical cancer. So making sure that we understand those risks will help us give better care to our clients. So why don't our clients sometimes get that care? Why are they feeling discrimination and stigma? Some of those reasons are because of barriers. And these look like long words, and you may have heard of them, but they are very important for us to remember and understand because they can help us change the way that we interact with our clients. So heteronormativity is this assumption that heterosexuality is the preferred normal sexual orientation. And so we end up with this kind of gender binary of male-female, and that's the preferred normal gender identity. When we are talking about gender binarism, we're talking about a classification of people as male or female, and that includes their biological sex, their gender expression, and their sexuality default to align. Heterosexism is when we assume that everyone is heterosexual and cisgender. So an example there would be if we look back to that very first slide for fun. You ask children and they may say that's grandpa and grandma, and that's kind of the normative and the heterosexist way of looking at that. And unfortunately, sometimes with heterosexism, the normal is seen as superior. And so if someone is heterosexual and cisgender, they're considered to be the superior sexual orientation and gender identity. And finally, where does that stigma and discrimination out? It's through homophobia and transphobia. And this is a fear and or hatred of gay or transgender people, and that's shown by prejudice, discrimination, and acts of violence. And so I've already talked a little bit about long-term care with regard to capacity, but what I wanted to do was just point out some of the new information that we are learning about residents in long-term care and being LGBTQ. And as I said, that feeling that going into long-term care means you go back into the closet. When we've talked to folks who identify themselves as LGBTQ and are seniors, what they believe is the most important type of support is to have respect and to have acceptance of their partner. They want to be able to share a room with a partner. They don't want to go into a residence where they are forced to be roomed based on their sex. They want to be able to have that relationship with their significant other. And they want to see that there are anti-discrimination policies in place and that something will be done if they feel discriminated against. They want respect as an LGBTQ senior, and what we do know is that many LGBTQ seniors and elders may age alone, as they may not have had children or they may have a estranged family. And we will see a change with that in the future, because now gay couples are able to adopt, and because of just the way that society is going in a good way, we're just way more accepting of folks who are LGBTQ, and so hopefully we'll have less estranged families. Unfortunately, we know in long-term care residents there are some challenges to being able to have non-discrimination and to be able to welcome people who identify as LGBTQ. One piece that is obviously going to impact how people feel when they're in long-term care is the response of the staff. And it's been noted that often there are homophobic attitudes that are displayed by staff, and that may be because of where the staff grew up in terms of their culture, or the religion that they practice or have practiced when they were younger, where in some of their cultures and societies, to be LGBTQ is actually against the law and holds very stiff penalties. So they struggle with coming to terms with seniors who are LGBTQ. There's often a high turnover of staff in some long-term care facilities, and what that means is that training that's given to those staff is not sustainable, so it doesn't get passed on to other staff. Some staff question the need for LGBTQ initiatives because they felt that they already had a culture of inclusivity, so why do we need to add more to our load? And what we also find is that there are actual residents of the long-term care facilities who will also have those homophobic attitudes towards LGBTQ residents. If a residence, a long-term care facility, has a faith-based aspect to it, if it's a religious facility, it is going to be more difficult to be LGBTQ inclusive. And as with resources and dollars, it was felt that there was a lack of resources for specific LGBTQ programming.
Here's another funny for you. Communicating way more than words. Gee, talk about your body language. One of my favorite expressions is that people hear your words, but they feel your intentions. And I think body language very much is tied into this. So what can we do? In fact, some of the easiest things to do are also the simplest. We need to be aware of our body language, facial expressions, and tone of voice. We know that over 90% of communication is nonverbal. We need to express an openness and willingness to learn about individual needs. And let's listen to what residents, patients, and their families are saying. Let's ask questions and avoid assumptions about people's relationships. Ask the question, what is your relationship? Who is your emergency contact? And we need to make sure that if we do slip up or make a mistake in our assumptions, we need to acknowledge this, apologize, and then move on. Of grave concern for people is the idea of the confidentiality and accidental outing. So we need to make sure that we do protect confidentiality of information and make sure patients and clients are aware of how this information is protected. A good place to start is doing some pretty easy and straightforward word swaps. And this is a way that we can make sure that we're using inclusive language and don't create some barriers where none were intended. And so, think about the scenario where you've asked somebody about their husband or wife when in fact they're in a same-sex relationship, and how might that impact your relationship with that person, or your therapeutic relationship with that person. When we could do some pretty easy word swaps and use the words spouse instead of husband or wife, or partner instead of boyfriend or girlfriend, or even for children as they're growing up, as we see same-sex relationships and parenting much more common, making sure that we use parent instead of mother or father. It's a pretty easy scenario to do some pronoun work, and the pronouns in particular are very important to people who are gender diverse or trans-identified. And so without making assumptions, if somebody is what we call the binary male or female by using the pronouns he or she, we can very easily get around it with the pronoun they. And yes, it is good grammar. We hear it quite often that people want to use they in a singular way, but in fact it can be used in a plural or a pronoun as a singular. We need to make sure that we are listening attentively and we reflect back the language that people use. We all know a Robert who goes as a Bob, and so would be of course very respectful and honoring of that individual to go by the name Bob if that's in fact how they've introduced themselves. In fact, again, when we're trans-identified or genderqueer folks, if they're using a preferred name or preferred pronoun that doesn't match the gender identity, we want to make sure that we're respecting and honoring that individual by reflecting back the language that they use. And here's a note about using of Mr., Ms., Mrs., Madame, Sir. I think that the time has gone by where, in fact, these are becoming less signs of respect than they were a generation or two ago. In fact, I just had a phone call today from one of my pharmacy companies, and they called me by the name Mrs. Wood. And in fact, and truthfully, I was actually quite offended by that. Although my name is hyphenated in most circles. In fact, if you knew me, I go by Miss Trout. And I did let them know that I didn't prefer to be called my mother-in-law, who is Mrs. Wood. So I think the time has come where, in fact, it's much more respectful to call somebody by their name than to use Mr., Mrs., Sir, and Madams. So what else can we do to create inclusive spaces? We talked about the use of inclusive language, but what can systems do? In fact, we can do a lot. One exercise I invite you to do is to walk around your spaces where parents, families, patients, and clients congregate. Do you have inclusive images on the walls? Does it represent both ethnocultural diversity, age diversity, but LGBT diversity? When we talk about considerations for people who are gender diverse or trans identified, one of the biggest conflicts or problems that they experience is the use of a washroom, which of course is a human rights. You know, for people that are not clearly identify somewhere on that spectrum and don't clearly identify as male or female, which washroom do they enter? Is it safe for them to be entering to that bathroom? A very easy solution is all-inclusive bathrooms. We've done a lot of work around all-inclusive bathrooms, and I wanted to give you a sign about what that might look like for your organization. You know, a toilet is a pretty standard side for this is a bathroom, but yet we don't have a gender or a sex assigned to that bathroom. And so I would invite you to again look around your spaces. Do you have all gender or inclusive bathrooms that people can use? What else can such systems do? In fact, there's a lot of things that we can do to create those safer and inclusive environments. We need to look at the forms, questionnaires, and processes that we have. Again, are images diverse and inclusive? Do we have literature that represents LGBT folks in the waiting room? Do we have those access to all gender or inclusive bathrooms? Do we have symbols like posting safe space posters or rainbow flags that are signage to indicate that in fact people are welcome and safe in those places? So Heather and I are going to leave you with a final thought, and this is a trailer to a movie called Gen Silent. We look forward to hearing from you in the future. Heather and I's contact information is on the first slide if you'd like to drop us an email. Thanks for your time, and thanks for listening.
A lot of people believe that you just live happily ever after, and that just is a myth.
People like ourselves, older, are hiding in nursing homes or whatever because they are scared to death.
It's incredibly common to go back into the closet again.
You just know when they don't want you there.
We've heard about homemakers going in, taking out a Bible and having the elder pray and asking for forgiveness.
And to be cured. It's not too late for you to be cured of this. They go back in the closet. She might mistreat me or abuse me.
They're so afraid of it, they are resisting any kind of medical attention.
That person was in their mid-20s during the McCarthy era.
The closet was the norm.
They could lose their job, they could lose, families.
We were sick. Just sick. We were
people.
considered sick.
People were involuntarily hospitalized in psychiatric facilities.
You mean electroshock?
The degradation of these people is so complete that their sex satisfaction comes only in being tortured themselves.
I was on the route to the nut farm.
So there's a real distrust of mainstream institutions.
I would never put myself in danger.
He became much more fearful of people knowing that he was gay.
You're not leaving now, are you?
Not right now.
LGBT elders are more likely than the general population to age alone because many gay elders never had children, have not had great relationships with their families of origin. There would be a higher degree of sort of alienation and isolation.
My family was the reason I existed, and I lost them all. If they ever choose to catch up before I die, I welcome them.
The LGBT aging issues are an epidemic.
There's a small and growing group of us.
We're trying to go into the existing network so they become more inclusive. One of the most common lines we get is like, we don't have any gay elders here.
If I wasn't the only person responsible for Alexander, I would have ended my life.
This is our life.
Good to see you!
Until the step in paradise, with a new step every day. We have a whole generation of people who don't know who we are. That's really sad, because you're missing out on a lot. We know a lot. We did a lot for you. You wouldn't be here if it weren't for us. Look at how strongly. Too bad I don't have an open casket.
Well, there'll be no open casket. There won't be anything, right?
If we are saying come out and be filled with pride, it's our responsibility to make sure that continues right through their last day.